There we go, and I'll share my screen. There you go. Okay, you should all be seeing my PowerPoint presentation of clear mutual expectations now. If you can't see that on your screen, please stick your hand up and I'll try and find out what's wrong. Okay, nobody is, so it seems that that's the case. What I'm going to do is talk a little bit about what clear mutual expectations is or isn't. Then go into a little bit into the theory of Safewards that lies behind this intervention. Then we'll discuss what it could or could not be, and finally we'll end up with looking at some of the examples which have been posted online. At any point in this proceedings you can put your hand up. I'll be able to then see that. We'll then pause and you can ask questions or discuss things with each other. I'll invite you to comment at various stages anyway. Once we've got to the end of all of that, we'll wind up the webinar and then we'll be finished. So talking about clear mutual expectations, what is clear mutual expectations? You'll all remember, because you've been involved in Safewards implementation, that clear mutual expectations is negotiating the staff's and patients' expectations of each other and codifying that and putting it up on the wall of the ward as a kind of a joint statement about standards of behaviour. So the important points about this intervention is it's codifying the patient's expectations of staff as well as the staff's expectations of patients. So it's a two-way process in which everybody's expectations of each other are being shared across the ward community for consistency and high standards of behaviour of both groups, not just the patients but also of the staff. So in essence, this is a kind of a long public conversation about how different groups sharing one space can respect one another more. What it isn't really about is codifying, in inverted commas, the rules for patients to follow so that the staff have an easier time telling the patients what to do. I mean, consistency is important about expectations for the way that patients will behave and also for expectations about how the staff should behave. But this is not really about just making things easier for the staff, and it's certainly not to make it easier for the staff to boss the patients around and tell them what to do. And neither is it just a pretty poster that does nothing or a mission statement, or as Jeff Brennan said to me once, and I put down here, not a thing to point to when things get tricky. Why is clear mutual expectations in Safewards? I've got a nice pretty diagram for you here that I did a long time ago, which talks about the structure of the ward. What we mean by the structure of the ward is, yes, the rules for behaviour of anybody, patient or staff, but also the routine of both those groups. So what happens when on your ward, how efficiently the ward works as an organisation, so how well does it actually operate in achieving the aims that it has, how quickly the patient requests get met, how quickly do the normal ward operations about prescription, delivery of treatment and all those other things that go on the ward, how efficiently do they go on? A well-structured ward will be a very efficiently run ward. Allied to that is how clean, tidy and well organised the ward actual physical environment is. And then lastly, there's the what I've called on this diagram the ideology or direction of the ward, but also what you can think about as being the shared purpose of the ward, everybody's shared understanding of what the ward is there for and what everybody is supposed to be doing together. And you can see there's a number of different ways in which this structure is actually made a reality on the ward. There's how it's communicated to people and shared between people and how consistently people operate it. There's how it's imposed on the actual social environment of the ward, and then there's the variance in the content to extent. So some wards can have a lot of structure, lots of routines, rules, and a very detailed ideology, and with other wards that can be relatively small. Most important thing around clear mutual expectations is the way in which that structure is actually delivered on the ward. Is it delivered in a respectful way, or is there no structure, or is it delivered in an authoritarian way? An authoritarian way is not likely to be successful. A respectful way is likely to be successful, and you can see that's how that structure imposes on, generates different rates of conflict with patients and different rates of containment. So you can have you can have no structure, or you can have an ineffective structure if it's being imposed in a really rather inconsistent and authoritarian, cold and harsh, an unpredictable way, or you can have a good, effective structure which is being imposed in a very, very mutually respectful way. And clear mutual expectations is an intervention that's targeted at trying to help you increase the effective structure on your ward. I'm just going to talk a little bit more about this before I open it up to questions from you all. So here's another diagram which comes from some of my earlier research, which is about how that effective structure actually has an impact on patients and the way that patients behave. So you can see up there on the top left is effective structure. Let me take a kind of a highlighted pointer here. There you go. Effective structure. I've got various windows have come up. Just give me pause. I'm having all kinds of troubles here with what I can see on my screen. Sorry. Let me just carry on with this. That's better. Let me go with the spotlight. Let me get rid of that if I can. Okay, effective structure. Sorry for all of these little delays. I don't know whether you're seeing exactly what I'm seeing on my screen, but what I've got is my little video window which is popping up. That's absolutely fine if you can see that. I can still see the diagram. So effective structure generates a number of different things. It makes the ward predictable for patients. So patients know what's likely to happen if they behave in certain ways. They know what the routine is, so they know what to expect. That effective structure, that external structure, we've heard from staff and patients, generates a cognitive clarity internally with the patient. So it cuts the degree of confusion which the patient is experiencing. It makes the relationships between staff and patients very clear, especially that structure around the ideology and purpose of the ward and what everybody is there for. It makes patients feel much more safe because they know what's likely to happen, and it gives patients a sense of predictability. All of that builds confidence on the part of patients, builds confidence in the staff, and builds their engagement with whatever treatment and therapy is operating on the ward. Moreover, that effective structure generates ward stability because it means that less conflict and containment is likely to occur. And it also gives a structure against which people's rehabilitation can be judged. So when you have a structure about what should or should not be taking place on the ward, you can assess the engagement or the degree to which patients are able to engage in that, which means that you can assess their progress towards discharge. And all of those things mean a therapeutic benefit. Like I say, I'm just going to carry on a bit longer. I'm having a little difficulty getting my PowerPoint to work. Right, there we go. Structure and attitude So when the structure's imposed in a kind of an authoritarian way, when people talk about sanctions and consequences of people's behaviour or of patients' behaviour, then that tends to be linked to a rather negative attitude towards patients. And interestingly, this more respectful approach to structure doesn't have anything to do with people's awareness of risk of violence. That's not associated with people's attitudes to patients at all. People have a more positive attitude towards patients, are more likely to recognise the need for consistency between staff. And what I mean by this effective structure approach is that it's based on a set of ethics rather than on the idea of reprimands and telling people off. An ethical approach to structure is about expressing a degree of equality with patients, so explaining to patients why these things need to happen in this way, listening to patients' feedback about what they think about having to behave in that way. It means that the staff admit fallibility, that their set of expectations for what patients should do might be wrong, and it means giving patients information about how they can appeal against that particular structure, rule, expectation, whatever you want to call it. An ethical approach to delivering structure is about the staff being honest and giving truthful feedback to patients, delivering on their promises and being genuine. And that ethical approach, that ethical making real of the structure also requires the staff to be courageous and assert that structure, and on occasions confront people who are not behaving in line with those agreed expectations. So as you can see, clear mutual expectations is based in all of this thinking about what structure is about. And within Safewards, clear mutual expectations clearly overlaps with soft words and with talk down. It's closely related to those two other interventions. So before we go on to what clear mutual expectations could be, I'm going to open it up to the floor, to you now, so you can make any comments about what I've just said, ask any questions, or share any of experiences of your own around clear mutual expectations. Put your hand up if you wish to speak. Or in the case of Kelly, type in a question. Kelly's not got a microphone. Okay, okay, Jeff, here you go. You've got the floor. You're on, Jeff.
Sorry, Dan. I just just to say that was actually really interesting. I haven't really made the connection with the effective structure thing, really. I guess it's just my thought of, and it's one of the things about mutual expectations. One of the things that people have often said is it a one-off thing, or is it something that needs to be revisited? I mean, my feeling is it needs to be revisited, but it's just a question of, can you get a structure that is generalizable to all situations, or is that what we're looking for, or is it something that has to be constantly revisited? Do you think a new set of patients brings the need to revisit it, go back over it, or is it a question of you can use the old one, but you just revisit it with new staff, or do you need to do them all over again with a new set of people? Do you understand what I mean? Because it's talking about the word in a very static, not in a static way, it's not what you mean, but it's a population that's constantly shifting. So how does that sit with, because the structure will be for everybody, but the population will always be changing. How do we?
I suppose this is a question about long-term implementation, really. And it would make sense to me, it would make sense to me if wards regularly reviewed their clear mutual expectations, I suppose at least annually.
Yeah.
Maybe every 6 months. I mean, some of that stuff is going to be core, isn't it?
Yeah.
But what you might find with a new patient group is that they have a different perspective, or might bring to the surface some new nuance of what the patient's expectations upon staff are.
Yeah.
And of course the policy of the hospital and of the ward changes in the interim as well. It might be that a ward changes from the kitchen being closed to patients to the kitchen being open for patients, and that clearly might make irrelevant some stuff which is on the Clear Mutual Expectations poster, so that would have to be updated.
Yeah.
So that would make sense to me. Kelly has put a question here asking whether anybody's implemented this in their ward environment, and is asking whether there have been any challenges. Have we got anybody here who's actually implemented it? Rachel Gwither, her microphone isn't working either. Rachel, have you implemented this? And if so, do you want to type in any response to Kelly? All right, so Rachel's saying she hasn't yet. Terence, I don't know where you are. Are you anywhere where it's been implemented? You stick your hand up if you are. No response from Terence. I guess the answer is no at this particular session, unless Rachel's. No, Rachel hasn't done it yet. Jeff and I have done it by proxy in that we've worked with wards who have done it, but that's not quite the same thing. The challenges are usually, and certainly I would speak for our experience during the trial here, is actually the consultation process with the patients. Sometimes that can take a protracted period of time. Even consulting across the entire staff group can take a while on a busy acute ward where there's lots of staff and nobody's ever all around at the same time. So that's one of the big challenges. The second challenge is to consult with all of the patients, and whether you want to do that as some kind of written exercise or on an individual patient-by-patient basis or in a series of group meetings with the patients. So that consultation takes time. Then once you've done the consultation, it takes a while to formulate that into really clear language that you're happy with. So the experience across when we did this as part of the trial was that this was one of the interventions that took the longest to get going because it took the wards a lot of time to negotiate and decide what it was exactly that they wanted to have on the poster. Then, of course, there are the inevitable delays that happen with getting something printed, and then once you've got it printed, finding somewhere on the ward to hang it. So it takes quite a lot longer than you think it ought to take. I suppose that's the primary thing. I'm going to ask Jeff if he's got anything to add to that. Jeff, you got anything to add?
Can you hear me?
Yep.
No, I would say that's probably right. I mean, both the two wards who immediately implemented afterwards, who had nothing to do with us, both of them said that this was the intervention that actually took longest. And I think, I mean, intuitively, you kind of feel that that's right, really, that it's not something you can start the process, but that you do need to. It is something that should probably take a while, at least. You couldn't do it in a day. You need to kind of take it through. And I guess the kind of staff to do the thinking before they go out. You talk about courage, but blind courage is a bad thing. But courage that's been thought through and planned is probably the best way to go about it. So yeah, it does take time. Yeah, but it's interesting because going around inpatient units after the trial, one of the things I've noticed is I have seen people with clear mutual expectations up who I didn't know were doing Safewards, and some of them are actually quite good. So I think it is something that some wards seem to intuitively understand. There is a sense that, because I always thought this would be the hardest, but that's not being. I don't think that actually bears out in actual out there. People do seem to get it very quickly. I was at a ward in Crawley the other day, and there was one on the walls, and it was their first kind of stab into Safewards. So that was very interesting. I don't know if other people have seen them anywhere else, whether they've implemented them or not.
I'm going to come in there and say one of the things that I see, or want to phrase this carefully. Sometimes it's possible to see clear mutual expectations that have been developed which have, unfortunately, quite a punitive or authoritarian language about them. And that's really not what we're trying to achieve here. So your clear mutual expectations poster should not have a list of instructions. Patients must do this and patients must do that. And not under any circumstances should so-and-so, so-and-so occur. I mean, the whole point of the clear mutual expectations is that it should be written in the same respectful manner that is evidenced within soft words, and then encapsulates those ethical values that I've just been talking about, that sense of equality with patients, that sense of respect and listening and treating people as adults. The other important component in there is that sometimes you find the posters that people develop are very one-sided. They're still all about instructing the patients what to do, rather than about culling from the patients what their expectation of staff is. Because that's the other side to this intervention. It's not just a matter of empowering the staff to be able to say consistently to patients, we all decided that this was the way that we're going to behave, and what you're doing now is not in line with that. What we want to do is for the patients to be able to haul the staff up and say, look, you, the staff, said that you would behave in this way, and yet this is not what you're doing now, is not in line with that. Jeff's got his hand up, and I'm going to give him back the floor. There you go, Jeff.
Just to say, that's very interesting, and again, I agree with that. I'm just wondering if there's any way we can signpost people to that, perhaps by looking back. This is an example of good language in a clear mutual. Not saying what the content is, but this is an example of good language, and this is an example of language people should avoid. Maybe it would be good to do a crib sheet. These are statements these are phrases you want to be careful about, or if there is anywhere else that people could go to look to make sure the language is inclusive rather than authoritarian.
Yeah, I don't know what we're going to see when we look. I haven't looked in detail at the posters that we've got on the net for a while. We might see some good ideas when we take a look at those.
Yeah.
Okay, I'm going to carry on because I've been having some thoughts really about what clear mutual expectations could be really. And I think there's a difference between explicating, it's the level at which you pitch things. I think you can pitch things at the level of specific rules, or specific expectations, like the staff will always be available to patients. That literally means if somebody comes and knocks at the office door, we will certainly give an immediate response and aim to give a more detailed response within 5 minutes, 10 minutes, this kind of thing. That's a very, very detailed expectation. Or they can be couched at the level of more higher level principles, like everybody on this ward will be kind to each other. We will all exercise patience, tolerance and understanding towards each other. The patients will treat the staff as they would like to be treated if they were the staff. And the staff will treat the patients as they would like to be treated if they were patients, etc. So I think we could try with our clear mutual expectations posters to get some of those principles in there, rather than getting bogged down all the time in the detail of the expectations, because it's the principles that we want people to be applying all of the time. And actually, with the level of detail around the actual expectations, what you really need on an acute psychiatric ward is a certain degree of flexibility, because you want to be able to apply things to people who are variably ill. Some people are very ill and they can't meet the regular set of expectations, and neither do we really, as staff, expect them to do so, but as they begin to get better, we apply a different standards of behaviour to them. But nevertheless, the principles behind our behaviour of kindness, consideration, tolerance and understanding for everybody should be there all of the time. So I think we could make more out of clear mutual expectations if we could bring to the surface our shared principles, and those things should be universally shareable as potential parts of clear mutual expectations, which is really why we want people to post their clear mutual expectations posters on the website so that everybody can look at them, for example. The other part I thought that we could do perhaps a little bit better with clear mutual expectations than we have done is set out the way in which those principles are turned into actions. That's kind of the middle bit in the sandwich, if you like. That's not the nitty-gritty specific expectations of behaviour, neither is it the high-level principles, but it's about how we are supposed to remind each other of those agreements. So if the patients have to remind the staff that they are not meeting those expectations, how would they do that? Similarly, vice versa, how will staff remind the patients? And I put down on this slide that we could put down on the clear mutual expectations how we expect that to be done with kindness, respect, and as much understanding as we should muster. And in a certain sense, because staff have the power, they have to make themselves open to be challenged by patients. They can't retreat. They have to say and elicit and invite patients to challenge them when their behaviour falls below those standards. And some of that opening out and making that invitation could be done via the clear mutual expectations poster. I'm going to pause now and invite some comments on this. This all might all be idealistic pie in the sky as far as you're concerned. Any comments from anybody? Okay, Terence, your microphone is live and you've got the floor. When you speak, perhaps you can tell us where you're from and what you're doing. Your microphone's live, Terence. I can't hear anything from you. Okay, I'm going to switch your microphone off and give you a chance to sort out your sound if you can. Jeff, I'm going to ask you, what do you think about all of that clear mutual expectations business I've just put up there?
Is that me?
Yeah, I'm asking you. You're on.
Yeah, I guess I like, to be honest with you, I like clear mutual expectations that are, I guess it's that whole thing about language, isn't it? That's, I just think, reflecting very much on what you say is when you go around, because sometimes you see them and they're very cluttered and the language is slightly staffy, and I think simple words like kindness, consideration, yeah, I think that's very important. But I'm just trying to think about the difference between generalized statements that you can't really nail down. You know, you weren't very kind to me. I suppose the difficulty I have, and I guess this is where the negotiation is to tease out the exact words that patients want to use for those things. Because sometimes you look at clear mutual expectations, you can kind of tell they're written by staff, and sometimes you look at them and think that's definitely been done. You know, or my gut feeling is, yeah, that's definitely done with patients because somebody's tidied up your language. Yeah. And I guess, yeah, it's yeah. There's lots going on in my head, but the disadvantage I think both of us have is we haven't actually done it. I'm thinking about what's this like to actually do all the time, really. And I
Well,
suppose the thing about challenge is if we're going to say patients can challenge, do we need to be careful that we say? I suppose the word challenge is a difficult one, isn't it? Patient can remind, or I don't know. It's challenge. Yeah, this even in that language is do we need to be careful that we're not inviting some kind of conflict? I suppose in a way.
well, I suppose what we're inviting is people to give voice to a potentially legitimate complaint in a
Yeah,
kind and understanding manner, which is likely to get them the resolution that they want, or at least the clarification that they want. And
yeah.
therefore, this would make conflict actually less likely.
Sounds like we're negotiating a clear mutual expectation, which is probably yeah. So I suppose it's like patients are allowed to remind staff that these standards are, something along those lines. Yeah, we invite patients to help us to maintain these standards by reminding us when we fall short. That kind of thing would be
And
stuff. Yeah.
it's that essential sense of equality that you're trying to generate, and that
Yes.
links back precisely to this difference between an effective and an ineffective structure. I'm going to carry on, and we're going to take I think we should move on now to some of the posters. I don't know where each one of these has come from. I've just culled all of the posters, and we'll take a look at one or two of them. And I think probably the best way to proceed is to think about what specifically we like about these posters. So we've got one on the screen now. If we all take a little moment to read that, we'll think about the things that we like about that specific poster. I mean, I suppose one of the things that I really like about this poster is certainly with the first six of the statements is that it's all about we, and it's got nothing to do with staff or patients. Same thing with 7 and 8, really. It refers to people rather than differentiating between staff and patients, and I think this is a good move on all of these posters. What else do I like about this one? Yeah, Kelly's saying that she likes the we as well. There's one line on there that if I was a patient I could read as a potential threat. I doubt if the people who wrote it noticed it really, but I'm looking at 11. When if I'm a patient, I'm being told I will be informed very clearly about the consequences of not taking my medication. I'm sure the people who wrote it meant the consequences being in terms of patients being more ill and it taking longer for them to be discharged. But potentially I might read that as being a veiled threat of being potentially restrained and medicated against my will. I suppose the more that you look at these things, the more that you can find in them. It's a bit risky, really. Anybody else want to say anything about this particular set of mutual expectations? Rachel's saying, I'm just repeating this just in case it doesn't come up on the video. Rachel is saying she agrees with the we, as it sets up more of a shared community and eases into the more specific expectations for patients and staff. Jeff, you want to have a word? The floor is yours.
Yeah, I mean, I think there's a lot to like, and I think the we is right. But I would say that this is what I was talking about in terms of clear mutual expectations, primarily written in staff language. I would say that, you know, you can, it's a perfectly good set, but I would soften up some of the, it does come across to me slightly as a list of, you know, and I don't think there's much work needs to be done. I think the principles are fine, but the language could just be softened up in a way, and I think, yeah, and I think the we is a very good start. So staff will offer space to listen to service users so they can, you know, we're all here to listen to each other, and staff will make special efforts to make themselves available to talk about feelings and concerns. You know, you could just soften the language up a bit. But as a set of principles, it's good. But, you know, I think another, you know, if you say this is our draft, can we make it a little bit more inclusive, and saying to the patients, how would we phrase this that would make you feel that it's, you know, that it is inclusive? It might be a good kind of next step.
Yeah. Rachel's just mentioned something that I hadn't thought about at all, is that she'd think about reordering the questions in the statements in a different way.
Mm-hmm.
Do you want to say anything more about that, Rachel? What would you do to the order? What I immediately thought when you said that was that you'd split up the we statements and put them amidst all of the other statements, so it gave a kind of a softer flow to the whole thing, rather than move from a we through people to service users and staff will and service users will. Is that what you were thinking of, Rachel, or did you have a different take on it? Yeah, I don't think Rachel quite agrees with me. She reckons the we statements to begin are good. How would you change the order then, Rachel? So she's saying having more of the softer ones first, maybe. It's a good point, anyway. Thinking about the order is as important as thinking about what statement should be on there in the first place. Let's move on to another example. We'll just take one more example. This was the one from Keats Ward. I have to say I like this one. This has got a bigger sense of us all together in here. And yet the actual content, the actual themes are not very different. All right, Terence reckons that that 4 is idealistic. I'm not entirely sure that I agree 100%. I suppose it's idealistic if you think that writing things up on a poster on the wall is actually going to stop any patient who might otherwise do so from bringing alcohol or illegal drugs into the ward. What it is going to do is make that more explicit. Jeff's got his hand up and wants to say something. There you go, Jeff. What do you reckon?
I was going to actually agree with your first point that it's interesting, a lot softer. Number 4, I think the word will should probably be should. I think there's a certain amount. That is very fingery. Yeah. The first bit's fine to help everyone feel safe, but no will be brought onto the board. It's kind of should be brought onto. You know, there's a. I don't. We all know that you can't stop it, but we all know you need to say to people it's not allowed, and it is about safety. It's not about being a killjoy. It's so I think this yeah, but I think it has to be there. I couldn't imagine that. I think the difficulty with not saying it's not rules is there are rules, and I think being clear about them is important. And I think alcohol and drugs is a big one.
And it's an issue, just as much of an issue for staff.
Yeah.
And there are staff who, there are occasions when there are staff who have alcohol or drug problems, who bring alcohol and or drugs onto the ward, and there are occasionally these events do happen, and so those rules do apply to staff as well.
But the content is very similar to the first one. It is interesting when you put them side by side. The language makes a big difference, I think.
Yeah, so I suppose that's a tip for everybody, really. Take a look at the examples that are available on the website when you're framing your own. And of course, the guidance with this particular intervention gives you a structure to think about as well. It will give you some ideas about exactly what it is that you want to achieve. Rachel is asking whether any mutual expectations have included other disciplines besides nurses that you know of. I think we've probably had occasions on which OTs have been involved fairly regularly, but I don't know about medics ever having been involved. Don't know is the answer to that question. So the idea that clear mutual expectations is idealistic is kind of reverberating around in my head. Do we expect these to actually alter people's behaviour directly? Maybe a little bit by making them explicit, but they're far more about framing what happens when the expectation is not met. So they're about putting a framework around that so that you can have a useful interaction with somebody when it comes to light that an expectation is not met, so that then within that interaction and how you interact around that failure of an expectation makes it less likely that that will occur again. I suppose that would be the answer that's in my head. I think we could probably sit here for quite a while and look at a lot of posters, and there are quite a few of them around, but I just want to finish up the webinar now by asking a few more questions and having a little bit more discussion. The first 2 of those and the first 3 of those have already been covered, but if there's anything more that people would like to say on those, now would be a good time to voice it. Rachel has put in while we've been talking that she thinks it'd be a good idea for medical staff to be involved, and people certainly have expectations of their doctors. I think that's a very interesting one. I don't know whether you could incorporate it in the clear mutual expectations as currently packaged, because there would be so much in there. Isn't there a lot of additional stuff in the doctor-patient relationship that could lead to expectations? I don't know. It'd be interesting for a ward and a ward multidisciplinary team together with their medical staff to try and do it with patients and see what such a set of clear mutual expectations would look like. Jeff?
I'm just wondering if Rachel has a dedicated inpatient consultant, because some wards have single consultants, don't they? And that might be those wards might be particularly pertinent to have the doctor involved. Some have multiple consultants, but I'm just wondering if Rachel has one consultant on the ward who covers the whole kind of piece.
You're doing it across 5 different wards or 5 different consultants, Rachel? Five wards, yes. So but does each ward have a different consultant? They have their own dedicated consultant.
Yeah, actually, I think that would be very useful to kind of have a conversation. Yeah, I think if there's multiple consultants, it's probably difficult. But I think if you have one inpatient consultant, they should at least, it'd be good to have a conversation with them about being included.
When I was a ward manager, I had 4 consultants I was working with. And
I mean,
this would have been hard.
Yeah, they should all have a lead, but but that's usually that usually doesn't happen. There's usually,
Even if they had a lead, the lead could not negotiate the expectations that the other consultants would be willing to fulfill, if you like. I think it'd be very good. Yeah, I think it would be really good for doctor-patient relationships if they were able to do it.
I think they should be invited, definitely, because they are part of the community.
What about Kelly? You're thinking about doing this. Are you on a single ward, and does the ward have a single consultant? Or Terence, what's your situation? So that would be possible for Kelly. Kelly's saying they're the dedicated consultant, and Terence says, Terence is out there in the community. Yeah, that's an interesting question as well. I have no idea, Terence.
What's the question?
Terence says, I'm currently working with mental health service users in the community and wondering if clear mutual expectations can be applied when doing community visits to form a basis of expectations on both sides, albeit not as formal as in a ward environment.
Ooh. That's one to chew on. It's a good question.
Oh, certainly a community team might be able to set forth what patients should expect of it in terms of a service. And it should be possible for the team itself to set out what they would believe to be the expectations of patients who engage with it. So in principle, yes.
Yeah, and you could get a representative group of the patients to help you with that. Yeah, it's a good idea.
So Kelly's saying she's a practice improvement practitioner, not working on the wards, but supporting the implementation of Safewards on the inpatient wards. Where are you, Kelly? Oh, that's right, North East London Foundation Trust. Okay, has anybody got any further questions about clear mutual expectations that they would like to have answered? Either stick your hand up or post a question now. Okay, nothing's coming through, so I'm going to bring the webinar to an end. Thank you everybody for attending. We'll post the dates for the next one shortly, probably just after, it's going to occur, isn't it, early in January, after Christmas. If you want us to cover a particular intervention or a particular one of the 10 interventions, let us know either via the forum on www.safewards.net or via Facebook or Twitter. Good luck with all of your implementation of Safewards, and I hope the webinar today has been helpful. And a Merry Christmas to everybody. Thank you very much, Jeff. Bye for now.